Thank you for joining us. We're now going to start today's webinar. Before we begin, I'd like to go over a few details for today's webinar. To ensure audio quality for all attendees, we have muted everyone's lines. That means you can hear us, but we cannot hear you. Even though your lines are muted, we want to hear your questions. To ask a question, use the chat feature that is on the right-hand side of your screen. You may have to click the arrow next to it to expand the section. We will answer questions at the end, after the discussion is finished. With that, I'll turn it over to Dr. Amy Eden, who will kick us off.
Thanks, Claire. Hello, everyone. Again, I'm Amy Eden. I am the director of AHRQ's National Center for Excellence in Primary Care Research, aka NCEPCR. And it's my pleasure to welcome you to today's webinar, which is our first of several planned for 2026. Before we get into the main content of our webinar about primary care research fellowships, I just want to start with a little bit of introductory information. Next slide. So zooming out a little bit, as you might know, AHRQ is a component of the U.S. Department of Health and Human Services. It is dedicated to health services research, which is the field of study that examines healthcare as it is delivered to patients, examining the quality, safety, affordability of healthcare delivery. AHRQ conducts and supports research into improving health outcomes, evaluating the strength of evidence for medical procedures, treatments, and preventive interventions, and investigating ways to improve healthcare treatments. Next slide. AHRQ is now under the leadership of Dr. Roger Klein, who's a board-certified molecular pathologist and attorney. He completed medical school and an internship at Case Western Reserve Medical School, residency and fellowships at Yale Medical School, and a fellowship at Mayo Clinic. He earned his law degree at Yale Law School, where he was an Olin Fellow in Law, Economics, and Public Policy. He's licensed to practice medicine in Ohio, Florida, and New York, and licensed to practice law in Ohio and the District of Columbia. He's a member of the U.S. Supreme Court Bar. Next slide. AHRQ's research priorities focus on improving patient safety and the effectiveness of healthcare for all Americans. Core areas include reducing medical errors, improving diagnosis and medication safety, and promoting appropriate care, including antibiotic stewardship and responsible use of medications in children. AHRQ is advancing digital health, telehealth, and artificial intelligence to expand access and strengthen evidence while reinforcing scientific rigor through real-world data integration, reproducibility, and innovative study methods. AHRQ also prioritizes high-impact conditions like long COVID, autism, nutrition, and chronic disease prevention, with a shift toward solution-oriented research that delivers measurable improvements in health outcomes. Across all areas, AHRQ remains committed to training the next generation of health services researchers. Next slide. So zooming in a little bit, AHRQ's NCEPCR focuses on a set of activities to support its mission, which is improving the delivery of primary care through the support of transformative primary care research and the development of tools and methods for implementation, as well as for the next generation of primary care researchers. Next slide. And I should say, so today's webinar is part of our effort to cultivate a robust primary care research workforce. And additional information and resources about NCEPCR generally can be found on the AHRQ website. Next slide. So turning to the content of today's webinar, our objectives for today are to learn about AHRQ's new Primary Care Research Fellowships and Centers resource, provide information on primary care research fellowships for prospective and early career primary care researchers, and then to highlight actual fellowship experiences of current and past fellows and how these fellowships have impacted their primary care research careers. Next slide. So before I hand the webinar over to our panelists, towards that first objective, I'd just like to introduce our new Primary Care Research Fellowships and Centers resource, which we designed to assist emerging primary care researchers. It basically just compiles a list of some external fellowship opportunities. And while it's not an exhaustive list, it is a great starting point for researchers who are looking to develop a career in primary care research. The resource also includes a list of US-based primary care research centers all of which are really working to address the many challenges facing primary care. And this is the barcode here, like before. You can access the resource directly. Next slide. So now I'm very pleased to get to introduce our moderator for today's webinar, Dr. Kevin Grumbach, a family physician and just a thought leader in all things primary care, including research. And he comes to us from the University of California, San Francisco. He has experience as faculty, and he can go into that, of UCSF's National Clinician Scholars Program, as well as I don't even know how many primary care researchers across disciplines who he has mentored throughout his career. So with that, Kevin, welcome and thank you so much.
Thank you, Amy, and thanks for kicking us off. And welcome to everybody attending the webinar and to our great panelists who I will introduce in a moment. As Amy mentioned, the focus of today's webinar is on fellowship training for people with an interest in careers in primary care research. Now, I'm very grateful that AHRQ and the National Center for Excellence for Primary Care Research and AHRQ is sponsoring this with a collaboration of APT Global. We're not going to specifically today focus just on AHRQ sponsored fellowships or career development programs. It's no surprise to, I think, any of you that it's a challenging time in many ways for some of the federal programs and sort of what comes next with some of their grant programs. I do want to make sure everybody understands that AHRQ has a long history of supporting workforce development programs, both through fellowship training grants. Those are known as the federal lingo T32 program. So AHRQ has for a long time put funding into institutional awards for fellowship training and health service research. Those are a bit on pause now, and it is also sponsored early career development awards for researchers known as K Awards, again with a focus on health services research. So there's certainly this background, and today we're going to focus though on knowing that there are still many fellowship programs, and there are also K-level career development programs that are active and in place both with federal and non-federal funding. And I think the overall objective today is make sure that people interested in careers in primary care research understand that there's still quite a lot of pathways available to them, and that people working in academic or other settings who are interested in how you build the infrastructure for these types of training programs realize that there are in fact still resources that are potentially available. So with that, let's transition into the panel section of our program today. Claire, if you could, I guess, have our panelists join us, and I will introduce each of them. So we have a really wonderfully diverse group of folks on our panel today. So we're going to start with two current primary care research fellows, and then a third individual who not too long ago completed a primary care research fellowship. So let me introduce you to Joshua Smith. Dr. Smith is a family physician. He's currently a fellow in the Robert Graham Center Fellowship Program that's done in conjunction with Georgetown University. Dr. Roberta Chardula-Reyna is a social scientist with a PhD in politics and international relations, which partly, I think, has given her a path to thinking in a more global framework around primary care research. She's currently a primary care research fellow at the federally funded T32 fellowship program at Pennsylvania State University. Dr. Hunter Holt is a family physician who's currently an assistant professor at the University of Illinois in Chicago. I shout out to Hunter for having completed his fellowship at my institution, UCSF, where he did the National Clinician Scholars Program, which I think it's important to acknowledge for the primary care researchers who are fellows in that program. That is also supported by a federal T32 Primary Care Fellowship Award. And then we're going to turn out to our seasoned members of the panel who are more overseeing and directing fellowship programs. I'll start actually with Dr. David Rabago. Dave is a professor at Penn State in the Department of Family Medicine, and he directs the fellowship program in which Ro is currently participating. And then Yalda Jabapour, who needs really almost no introduction, I think, to this audience. Yalda is the director of the Robert Graham Center in Washington, D.C., and is very involved in their fellowship program in which Josh participates. So, Josh and Ro, you can talk about your programs, and then we're going to check in with, Dave and Yalda to just get a little, reality check about all this on those programs. All right, so this is going to be an open conversation, and then as Claire mentioned, we certainly invite people who are in the audience to put in questions in chat. So let me start with you, Josh. Josh, what was your road to gaining an interest in wanting to develop your research and policy skills in primary care, and what led you to matriculate in the fellowship program at the Robert Graham Center?
Yeah, well, thanks, Kevin. Thanks, AHRQ and APT for having us. I think my path to primary care research started with my path to primary care in general. I think as a lot of physician scientists and physician researchers, we find what we're passionate about in our preclinical years and through our clinical years of medical school. And I really fell in love hard with primary care. And I saw the value that primary care brought to our patients, especially those patients who were falling through the cracks of the traditional medical system. And in all of my work, I realized primary care is the solution. Primary care is the solution. And then these bigger thoughts started ringing in my head of, well, why the heck can't we pay for primary care? Why is our primary care system crumbling before my eyes? And those thoughts just kept nagging at me as I went through medical school. And then I went to University of Cincinnati for my residency training in family medicine and psychiatry. And those thoughts kept nagging at me, which was, we know primary care improves all measurable health outcomes. We know that we are the linchpin for patient well-being and the well-being of our system. Why are we struggling so much? And so this question of how are our financial incentives structured? How are our teams structured and supported in caring for our patients? And I realized that those were questions that I really wanted to answer. And frankly, I had no idea how to answer them. So I knew the questions and I knew the value of the questions, but finding those mentors to teach me how to do this good primary care research and really use those data that are out there to answer the questions led me to this search for the fellowship that was right for me. And, I can talk about it a little bit in a moment, but obviously the Robert Graham Center was the right place for me because they were answering the questions that I wanted to ask, and I wanted to join that team and learn how to do it.
Terrific. Well, you are at the right place, clearly, Josh. So that's great. Yeah, you remind me, I did a fellowship in health policy and health services research at the Institute for Health Policy Studies at UCSF. And I think you said almost word for word what I was feeling at that time. Here are these broader issues, and what do we need to do the research and translational policy to change those broader factors that shape primary care and the health system. Rose, so maybe let's turn to you. So you, again, part of the message from the webinar today is to make sure people understand we really are enthusiastic about people who are not necessarily clinicians with clinical training, but those who bring other perspectives to be part of the kind of community of folks working in primary care research. So how did you go from politics and international affairs to a research fellowship at primary care at Penn State?
That is a great question. So yes, thank you, Kevin, and thank you for all the webinar organizers. So I will say that my path to primary care involved a lot of serendipity and making the right connections and being willing and open to sort of like dive into a field that at the time wasn't my, something that I had experience with. And so, as you mentioned, Kevin, I have a PhD in politics and international relations from the University of New South Wales in Australia. And shortly after I moved to the US, I got a job as a copy editor for a medical humanities journal hosted at Penn State College of Medicine. And in that job, I got to work with some wonderful faculty who did research at the intersection of medicine and humanities. And one of those faculty was Dr. Benjamin Levi, who is an ethicist and a retired pediatrician, and who's an expert in child well-being, child health and well-being. And he had received, a lot of funding from the NIH to conduct research on child abuse and mandated reporting, which is, when an individual is mandated by law to report suspected child abuse. And, I had been through my international relations background, I had always been interested in these sort of like big issues that transcend national boundaries and also that require interdisciplinary and multi-sectoral approaches and solutions. And child maltreatment is one of those issues. It has a primary care dimension. It has a public health dimension. It has, a social political dimension, and it requires interdisciplinary research for to be addressed. And it also has an international dimension. It's evident in instruments like the Convention on the Rights of the Child, which has been ratified almost universally. And so as I became involved with Dr. Levi's project, which is called the I Look Out for Child Abuse Project, I started finding a place where I could really make a difference using my political science and global, international relations training and knowledge. And I also at that point realized that I wanted to start doing research again. And I shared that with Dr. Levi, and I said, I don't want to be a copy editor anymore. I was doing some grant work at the time as well. I said, I don't want to be a grants administrator anymore. I want to become an independent researcher. I want to become my own PI, and I want to make a difference through that. And so a couple of days later, he called me and he said, there's this T32 fellowship where you would be able not only have the time and space to do research, but you would also be trained, have structured training and mentorship to become your own PI. And so, if I'm asked the question, how did I find the fellowship? I would actually say that the fellowship found me. So I think I was at the right place at the right time, and also open to finding new ways to apply, my traditional, my research training and skills, so that I could actually really make a difference for, people in the US and elsewhere.
Terrific, Ro. Fascinating, really important work. So yeah, let me just follow up then. How has it felt bringing your expertise and your perspective to this fellowship? I mean, is it a good fit? Does it feel like it complements things? Are there times where it seems, I'm a fish out of water, or no, this is really a place where I can be part of this, primary care research community?
So thank you for that follow-up question. I think it was a little bit of both. There are times where I do feel like a fish out of water, and that, sort of like one of my challenges is sometimes to justify and explain, sometimes even to myself, the value of my research and the value of my sort of like methodological and almost like ontological, approach to research to a primary care audience. But I think that but at the same time, it has been a great fit because our fellowship is inherently interdisciplinary. And I think primary care is a field that requires different ways of thinking. It's not just the biomedical way of thinking, right? We need to think about social determinants of health. We need to think about things that are broader than just medicine. And inherently, our fellowship is multidisciplinary. And so I do think that because of that as well, while sometimes I feel like a fish out of water, I do feel like it's the place where I should be.
Yeah, it's great. Sounds like you're enriching that aquatic environment, shall we say, for all the people
I
in
hope
the
so.
program. So, Hunter, let's turn to you. So you completed your 2-year fellowship. You made it into a faculty position. Could you maybe just again reflect a little bit on what got you on the path to doing a research fellowship, and then particularly what's that transition like after you've completed a fellowship to land in a position for the next stage of your career?
Oh yeah, thank you. It's a lot of what Roberta and Josh said. I think that a lot of what their journeys are very much like my own journey. I would say that, I'm a first generation college student, and as a first generation college student, you're also a first generation medical student. I went into medical school wanting to be a doctor, and as a first generation, I really was ignorant to what medicine was. It was to me, it was primary care, right? I remember with me and my 2 brothers and my mom seeing the same doctor on the same day. And now being a doctor, I know that was probably a very difficult day for that physician. But that was who I thought of was a doctor. And that's the person that I wanted to be. And so I went into medical school wanting to be primary care, not even really knowing what a family medicine doctor was, or med peds or internal medicine. And then really getting into residency in a family medicine and working in a federally qualified health center, and really hearing my story in so many of my patients, and really reflecting on my patients' stories where they dealt with being of a lower socioeconomic status, their parents working multiple jobs, lack of insurance, lack of healthcare access, and really reflecting on why was I so lucky? Why am I the exception, not the norm? And so that's really what pushed me towards research. I did some cervical cancer work in medical school as a Fogarty Fellow. So if anyone is interested in Global Health Fogarty International Center work, please reach out to me. They gave me money, so I have to pitch for them. It still exists too. So if you're interested, let me know. Pre-doctoral and postdoctoral scholar programs. I saw patients in my federal qualified, the one right here, this one right here in the background, missing their cervical cancer screening follow-up tests after abnormal screening test results. And I don't have a cervix, full disclosure, but this is a completely preventable disease. This cancer shouldn't be happening in the United States or the world in that matter. And so really, I wanted to address that issue. And so, medical school and residency does a great job of teaching you how to be a doctor, but it does a really, really poor job at teaching you how to be a researcher. And so I feel that everyone in this virtual room is already way ahead of me, because I remember just getting on Google, and this was before ChatGPT made everything super easy, Googling primary care research fellowship or family medicine fellowships or research fellowships, and there was nothing, or there was no infrastructure. The materials that the AHRQ is offering you all is so much better than what I had just 6 years ago, which is crazy to say that's not that long ago. And so was very, very lucky to end up at UCSF. It was some of the best years of my life, even if it was during the pandemic. Maybe that made it better, I don't know. But now I'm back here at UIC, back at the institution that really inspired me to answer the research questions, trying to answer those same research questions that I had as a resident so long ago, and reflecting on what is it like to be that early career faculty. It is a big transition, especially as a clinician scientist, coming from that clinical background, trying to balance clinical work. I'm sure Josh has dealt with this too. Kevin, you, and I'm sure David he's in clinic right now, or dealing with it, or continue to deal with it. But I think that the fellowship is absolutely critical. I tell every one of my mentees, and one of my mentees is in the audience now, is that if you're interested in being a clinician scientist, these fellowships are absolutely 100% critical. When you're talking to a chair of a department and you're saying, I want some time bought out for research, you're going to need to be able to say, like, hey, I have this amazing training. Hey, I was an NCSP fellow, or I was a Graham Center fellow, or I was at Penn State, and I got this master's degree, and I got all these publications, and I have this amazing mentorship, and I have the guidance to really achieve what I want to achieve, and my vision for my research and future career. And I think that wherever that is, fits perfectly with it.
Let me thank you all three. This is so compelling. So great. Thank you for sharing your stories. Before I turn to Yolda and Dave, I realize I want to come back, particularly Josh and Hunter. because I'm seeing some questions already coming in chat, and particularly I think for clinicians and physicians, as you're finishing your residency training, right, there are positions in pretty much full-time clinical practice that will compensate much better than a research fellowship position where you're essentially at a PGY 5 or 6 kind of salary. So you are deferring kind of a level of compensation that one would be getting as a otherwise practicing physician. Can you just talk for a little bit about how you decided, I think I can afford to do this, or are there, Hunter, I don't know if there were loan repayment or are there any special programs one can potentially pursue to help make that financial choice a little easier? Hunter, maybe do you want to start reflecting on?
So yeah, so I mean, I am on the public service loan forgiveness program, and I'm pretty sure almost every single one of the research fellowships are going to qualify as a public service loan forgiveness option. And so I think that's one thing to really consider. It still exists. It's in my master promissory note, and so I continue to work my way towards the 10 years. I'm almost there now. I mean, it's a big decision, and I would. It'd be a very difficult decision if I was a attending physician making an attending physician salary and then thinking about research. That's why I really, it's not that it's impossible. It's definitely possible. I mean, to go back to fellowship and maybe potentially take that pay cut, so to speak. But that's a reality of this sort of thing. But if it's something that's passionate about you and you're in an academic setting already, I do encourage you to talk to your chairs. I know Kevin was previously the chair at UCSF, and so I don't know what the request would look like for you, but I know that in our department, someone was really was just primarily a physician in the same clinic and behind me, Miles Square, and was really interested in research, and talked to the chair of our department and was like, I can do it, and got 3 years of their time bought out, and I think it was like 50% research and 50% clinical time, and was able to obtain their K award after being an attending for 10 or 15 years. And so that's probably rare, but I think that having those conversations and talking to those people are options that you should consider. The loan repayment program is one that does exist. If you're pursuing public service loan forgiveness, it doesn't always make the most sense, but it definitely is an option to consider. I know a lot of my co-fellows actually went and pursued that and were able to obtain it.
And I think that's great. There is also the NIH loan repayment program that fellows are at least eligible to apply for. It's a competitive program. I believe it still exists, but particularly with the kind of equity work you were doing, Hunter.
No, that's what I was. Yeah, sorry, NIH loan repayment. That's what I was making.
Yeah. Josh, do you anything you'd want to add about that decision point?
Yeah, I think for me, part of it was looking at the structure of the fellowship. There's variation in the duration of the fellowship. Now, I would have come to the Graham Center if it were a 5-year fellowship, but it is a 1-year fellowship. And so having 1 year of deferred earnings compared to a longer fellowship was an easier choice for me, especially because, as you, Kevin, and Hunter alluded to, most jobs right out of residency are not going to be able to give you that package with the time to develop your own research portfolio and your own skills. So I knew that I was going to pay the price at some point, but coming to a fellowship allows me to go to department chairs and say, I'm a safer bet than I would be if I was just out of residency. How much time can you give me that's non-clinical to really build up my foundation and build up my portfolio? And that just wouldn't have been able to happen. I wouldn't be able to have that conversation with a straight face without having done the fellowship.
Well, it's an investment in one's career, interest in doing the work you want to do for the rest of your professional life. Dave, let's turn to you then as the person directing a fellowship. And I know there's a question that came up already in the chat about how does one even launch a fellowship? So could you maybe go back to developing the Penn State program and how you pulled that off? Dave, I think you're on mute maybe, so if,
I can control that.
Yeah, there you go.
The mic is really small. Thank you, Kevin, and thank you, organizers. It's been my pleasure to join the webinar today. Yeah, my history with fellowship is actually pretty long, and started in 2001 when I was a HRSA T32 fellow, and launched as Josh and Ro and Hunter have been talking about, early career, and eventually, you know, you do enough clinical work and then enough teaching, you embark on a little bit of research, and then Ro mentioned serendipity, and I think that's really fortuitous. I was in a position where I could join the leadership team of the fellowship at the University of Wisconsin, where I was at that time, and started to learn about the management and the infrastructure associated with fellowships, kind of behind the curtain. When I came, and eventually directed that fellowship, when I came to Penn State, there was no fellowship. We did not have a primary care research fellowship, and the institution did not really know anything about that. And the department, although it had academic fellows, and the internal medicine, general internal medicine also had academic fellows, they did not have any research fellowship. So before even embarking on applying for a structured fellowship that comes through a grant application and an RFA and so forth, we decided to just try and model some of the research training practices that we did in our fellowship in Wisconsin at Penn State. And we did that without a funding stream, other than the interested clinicians' own time. So we were recruiting for clinicians, and one of the persons that we were interested in recruiting said, you know, I'm interested in some research protected time, but I don't have a lot of training. And we thought, well, how interested are you? And it turns out she was very interested, and she had a lot of drive. And we kind of put together a financial model with the operations group in our department at Family and Community Medicine. And we said, how much would it cost? How much clinical time does a person needs to do to kind of pay for themselves? And can we have a revenue neutral fellowship for just one person, and move through some training steps, have some mentorship, perhaps set the person up for time to get a master's in public health, as she wanted to do. And we had a very enthusiastic chair in Mac Ruffin at that time, and an interim chair, Kevin Black, who was likewise interested in growing the research footprint across the College of Medicine at Penn State, but particularly in family medicine. It's a really big department. And I will say that was a fortuitous catch, because that fellow, Alice Zhang, is now a K recipient internal to our program through our CTSI, and a K23 recipient through NIH, and a very productive junior faculty member. Relevant to the question that you ask, how do you start that more formal application to a T32-like thing? She turned out to be our pilot data. And we don't, like, we say that in quotes, and it's a wink, wink, nudge, nudge kind of thing, because she's, you know, a productive researcher in a fantastic field. Harms reduction in a number of areas is her wheelhouse. But she also was our pilot data. And the answer to the question that HRSA really is interested in is what makes us reviewers think that you can do this, was we have done this with one person, right? And so we amplified the model that we used with her, and that structured the how-to, the methods that we incorporated into the fellowship later. So the short answer is, any academic family medicine department can theoretically do this. because if you have any researchers in the house, they can be, with a research portfolio, they can mentor a junior faculty person. It can be structured in any number of ways. I think we called her an instructor. She wasn't making faculty wages, but she was making more than T32 federally mandated fellowship wages. It was kind of an in-between position. And that worked. And kind of was the nidus around which we built a more robust program. Her example allowed us to apply in the next year for the formal fellowship RFA that HRSA released, and we were fortunate to be funded in the following year. But anybody can do it. Not anyone, but it doesn't require so much infrastructure that you think. It requires a skilled mentor or two or three with some research portfolio and experience who can provide the mentorship and the coaching. And I can't overemphasize the mentorship, the coaching, the kind of the path finding that a person who has less experience and less training really does need. It's a complex, research is a complex environment, but a learnable one.
So, terrific, Dave. And again, just so everybody in the audience is clear, the source of funding for now your fellowship that's well established is they go by the name of HRSA NERSA T32 awards. They're actually administered by the Health Resources and Services Administration, but the funds actually come from the NIH, National Science Research Administration. So they are available. And Dave, did you succeed on your first application to get an institution?
We did. The timing was fortuitous, and actually, it was actually built into our my wife and I coming to Penn State, and that was 2020. The grant is 21 to 26, so it happened real quick. She arrived more or less when I did. We interviewed her for the faculty position. She said, I wanted to research too. And so they kind of were hand in glove. The timing couldn't really have been better, but yes, it was first pass. And the HRSA system doesn't have, it's one and done. It's one cycle. The whole cycle of 21 programs applies at the same time. They had they don't tell you how many applications there were. I'm guessing there were 70 or 80. And all of those you're either in or out. There's no renewal, or rather resubmission process.
So it is a competitive process for people.
It's a very competitive process, yeah.
Limited number, but to be aware of that.
Yeah.
Dave, when Dave was talking about their pilot fellow that was internally funded, this sounds a bit like how you've approached it with the Graham Center of Georgetown. Do you want to say a little bit more about how it's structured?
Yeah, so the Graham Center, actually is not formally a part of Georgetown University. We're actually formally a part of the American Academy of Family Physicians, where, you can consider the research division of the American Academy of Family Physicians. But from the moment that the Graham Center was created, 2.5 decades ago, we have always hosted collaborators, learners. Kevin, you might have been one of our scholars in the past. And so the team here, that's made up of a combination of physician researchers, but also social scientists, geospatial experts, was very used to mentoring both clinical and non-clinical learners. And then comes Georgetown, who is, located in Washington, D.C., and we had very close ties just because of, being located in the same area with Georgetown University. And Georgetown University had applied for a HRSA PCTE grant, which they were awarded. that allowed them to fund a fellow who would also work out in the community and would be community-based. And so that's where the formal funding relationships started for the fellowship. And at the time, the fellows, and still the fellows were required to work 40% clinically. Now it's shifted a little bit, and we can talk about Josh's breakdown, but under the grant, they were working 40% clinically. So, partly funded by the grant, partly funded by their clinical revenue. They were working in a local federally qualified health center. And then their research home was the Robert Graham Center. And so that's how the collaboration started. And the fellows, the fellowship, as Josh said, it's 1 year, quick turnaround. And the fellows all ended up, with really successful academic careers, really learning how to do research, how to apply for grants that they could take with them, as Josh has mentioned, to a chair and say, I'm ready for an academic career in research. I've had this 1 year focused on this. And this became a way to grow the network of primary care researchers. And both Georgetown and the Academy became very invested in this. So even after we lost our HRSA PCTE funding, it's been, pulling resources from both places to make sure that this can continue to be funded, because they really value the fellowship and see the importance in growing the primary care physician research community. Obviously the fellows still work clinically, so they get paid as a PGY4. Their revenue pretty easily comes from, their work in the clinical setting. They can work in a variety of clinical settings. Now that we don't have the HRSA PCTE grant, they don't have to work at a federally qualified health center. Some work at, the faculty clinic, some work at the residency clinic at Georgetown, some continue to work at federally qualified health centers. It just depends on the fellow's desires. They also don't have to be a family medicine graduate. They can be any primary care residency graduate. So we've had internal medicine in the past. The family medicine graduates, though, are also expected to precept in the residency, and they do inpatient if they want to. So it's really a mixture of funding sources that got us started and keep us going. I also think that the fellowship is unique in that, not this year, sorry, Josh, but in past years, the fellows have also had the opportunity to spend a day a week at a government agency to see what that career path is like for a physician who, some physicians want to continue after the fellowship and do research work in academic settings, and some want to do research, but not necessarily in an academic setting, but under a federal agency. So we have both paths.
Terrific. I see Hunter's already excelling at multitasking and answering questions directly in chat with very thorough and insightful responses. So I trust people in the audience are able to tune in to see the responses in chat that are getting at some of the questions. This career trajectory is, I think, coming into some of the questions and people have talked about. And Yalda, I think it's great to make sure there's ways of, if one has an interest in research in primary care, often I think people in primary care are very interested in its translation both to practice and policy, but that there's ways other than the traditional get a position in an academic department and get grant support for your research program, the row, as you talked about, establishing oneself as a PI, independent investigator, and things like that. But there are also some other career paths that I think fellows from the Graham Center and other programs have done. So maybe let's just talk about that a little bit more, because I think we know the traditional, and Hunter, maybe we'll come back to you to just say, what was that like? And what does it take to make that transition? And then Ro and Josh, your thoughts about next steps. But there are certainly other pathways. And I think some of the questions come up. I mean, you mentioned there's government positions and people, like Amy. Amy's a good example. We should have Amy on the panel as well. So Amy Eden, is a anthropologist, I think is your background, Amy, a qualitative researcher who had then been working at the American Board of Family Medicine on their sort of internal research team, and then has gone on to AHRQ and is now the director of the National Centers for Excellence in Primary Care Research. So that's, again, an example of a type of path that wasn't through the go into a faculty academic position. There are other ways to, I think a number of people working in government positions and things like that. I think the other one that somebody in chat talked about was health system leadership positions. Somebody mentioned, for example, things like informatics, or now AHRQ has also really emphasized the notion of learning health system research, which is much more applied, pragmatic study of what is actually happening on the ground in health systems with rapid turnaround to inform improvement activities and policy changes within health systems. So I think there are lots of avenues. There are actually AHRQ is a sponsor of the Learning Health System Awards. What are the E-Star Awards is the acronym now, but those are institutional awards that, again, really is a different type of fellowship that is more on this idea of learning health system research and system leadership pathways. So I think there are all these things that can be different ways of where you go from this. Hunter, maybe can you just talk? I mean, it's not easy though if you are interested in academic positions. So let's just start with you. I mean, it's a little bit like, where do you get that first step? How do you get the K? Do you need the K before you get the faculty position? Do you get it once you get a faculty position? And then Ro, I think I'd like to pull you back in and just have you think about a little bit how you think about where you go from this with your fellowship training. So Hunter, let's start with you.
Oh yeah, it's a really important question. It's probably one of the more difficult questions to think about. As Josh and I, and we've all alluded, a physician's salary is higher than a traditional just PhD researcher, and for what that is, what it is, and potentially because you're doing clinical time as well. And so if you are going into this job and you're talking to a department and you're saying you want to have 50% of your time for research or whatever, or 75% of your time for research, that's just time you're not in the clinic. That's time you're not seeing patients. That's time when you're not generating revenue for the department. And so it's hard. And that's why I think the fellowships are really critical here, to kind of allow the department to believe that, hey, this guy or girl or person or whatever your gender pronouns may be, wants to do research, and I think that they can do it based on their training. And I think that that's where the fellowship is absolutely critical. But what does that transition into? And so from my humble perspective here, as a clinician scientist, I think that 2 years as a fellow was great. I don't know if it was enough for me. I think coming from a PhD perspective, it's a lot different, where your whole entire training was based in research. And so that's up to 6 to 7 years of your life. And now you're doing a research fellowship on top of that, Ro. I can't believe it. And so like things like setting up a lab for me are still mysteries that I still have no idea what a lab even means. But with that all said, so I was talking to Thomas in the chat. I think one avenue to really consider, and really everyone that I've always talked to, is to think about career development awards, especially in those first couple of years. And there's a lot of different opportunities there. If you are, applying to jobs, and you're thinking academic and research, I would definitely look at academic positions that have internal K awards. And so that would be through like the CCTS or the Institute of Translational Medicine. Most academic centers have them, and they are sponsored by the NIH and have internal funding for KL2 grants. There's also the Birch program, which is the Building Interdisciplinary Research Careers in Women's Health, which I was a recipient of, and that's another offshoot that is funded by the NIH for career development. And these awards grant you 75% of your time for research, and then 25% of your time for clinical or other things. PhDs are also more than welcome to apply to these internal awards as well. But it really gives you that foothold that you need to really launch your research career. The UCSF, I was always, and I followed this advice, is you can do the internal K and then you can transition into the external K. There's pros and cons to that. I'm on that route myself right now, but the big thing is that that's 75% of your time that's on one grant and training. You're not allowed to participate in other grants for an extended period of time, which is difficult to navigate sometimes. But I would say when you're thinking about the job and thinking about that next steps is you need to have that plan, and you need to demonstrate that plan to whoever is hiring you, that I am going to join your department and I'm going to apply for the R21. I'm going to apply to the KL2 in your at your university. I'm going to utilize with your resources, and I'm also going to apply to the external K through AHRQ when they come back. When I said when on purpose, and then the NIH as well, and so that really provides that that understanding that you know what you're doing and you know what you're going about. If you're already at the department, I think that it's still very feasible to apply to one of these. It's just, as Thomas had said, he was doing a lot of this on his own free time, which is, maybe not optimal, but if it sounds like this is what you're passionate about. And I think that that's the avenue that I would take personally, is just be working on this at all times and talking to the mentorship. I mean, you're at UPMC, you're going to be able to find amazing mentors there and come up with an award and apply. And then hopefully, but you'll have to talk to your chair as to support your time. There's this K gap that is often a specter on that sort of thing, though most people are really happy to fund them because they are very prestigious awards. And so I will stop talking and transition to someone else.
So let me call people's attention, well, just for a moment. Eric Bass is on. Eric is the executive director of the Society of General Internal Medicine. So Eric, thank you for joining. I realize it's a bit of a family medicine centric panel today. And it's really important to know that there's broader, there's other fellowship programs here. I think some, these links that have been posted in chat, people should look at. Eric just put one in for general internal medicine fellowships. There's an earlier post there, and maybe Diane, we can put them in just so they're front of mind for people. There's the AHRQ has just put out a great resource list, and then there's the NAPCRAG and Associations of Department of Family Medicine collaborative work on making this available. So I think, as Hunter, you were saying earlier, partly the goal in all this is to not make it so hard for people thinking about research careers to know what's out there, and for people thinking about developing research programs at their institutions to have some resources or where to look for some examples. So thanks. Hunter, I just want to come back to your point. See, knowing you, you're humble, and I think understating this. That step from a finishing fellowship to getting a faculty position, let's say as an assistant professor, while then you're working on a K award, means there has to be a department that is willing to use department resources to fund salary support. Usually it's going to be at least 50% for somebody while they're taking the next step in their research career. So this is a big deal, and it's where it's often hard in primary care departments, whether it's general, division of general internal medicine, pediatrics, family medicine, nursing, Department of Nursing with nurse practitioner programs. There's frankly, subspecialty departments tend to generate more clinical revenues that then can build a nest egg in the department to subsidize, the quote protected time for researchers. It's harder in primary care. So I think, Hunter, when you went to University of Illinois Chicago, I think there was a fairly new chair, right, that had been appointed. I think had gotten the dean's dowry for a new chair appointment and had some resources available. So that's a reality. I think it takes department resources to do both fellowship support and then ongoing support for people as they're transitioning, and even under full NIH or AHRQ R-level awards, there's often still salary, there's salary caps that often require some departmental matching funds. So these things, I think, require investment. And I think this is where coming back, having been chair of a department of family medicine for many years, it has to be something that is one of the priorities of a department, and to look at both clinical revenues and any margins you're able to generate as one source, and to be respectful of all the hardworking clinicians and understand that's part of working in an academic health system and the department, is that is partly the clinical revenues are helping with the broader academic mission. It's, I think, where philanthropy becomes really important in finding funders. And again, it's more challenging often in primary care where it's not a single disease or a grateful patient who's had a loved one or themselves, cured of cancer. So I think one has to be very resourceful because everything from a fellowship program to K awards to early career and even well-established researches requires a considerable amount of department and institutional funding in our department. Again, we've always had partnership with the dean's office to help with some matching funds for these kind of things. So I think YALDA there, the Academy of Family Physicians, but I think these are critical things that you can't do it alone. Usually as a department in a primary care field or division, you need some institutional and broader support.
I think that you raised really good points. I mean, right now we have a couple fellows that would love to stay on as research faculty at our institute, but unfortunately, we just don't have that money right now, and they're looking at other options. And so that would be my big advice for a lot of people if you're looking for job options: is email a lot of people and talk to your department. I know that our chair has emailed a lot of different people to be like, hey, this is one of our academic fellows. I think, Kevin, you sent a couple emails for me introducing me to department chairs. That's one of the benefits of the fellowship is you get that networking. Even though I thought I would end up in a job where networking was not a part of the part of the pie, it's definitely part of the pie, unfortunately. But so those introductions. But I was very successful with just cold emailing a lot of people. I actually think I cold emailed you, David, to ask about your about Wisconsin's position when you were back there. And just seeing, is there any jobs available? And so really, you just keep emailing people and send a reminder email after a week. People are busy, and so you'll be surprised how far that'll get you. Especially when you're seeing your family medicine or internal medicine or primary care clinician that's interested in research, you'll be able to go pretty far with that.
Well, let's bring, so Hunter mentioned, once it's a lot of work to get a PhD and a lot of scholarly work that's gone into that, and then to do the fellowship. First question is, is the fellowship still pretty important for people with PhD or other degrees of that nature to position themselves to become more independent or full-fledged investigators? And where do you see as the next step for you on your pathway?
Yeah, thank you. So it is very common for people with PhDs to pursue a postdoc afterwards, a postdoctoral fellowship, or even a postdoctoral position, say in a particular grant, a year-long position. I do think, however, that I was lucky in this fellowship in particular because it's a training fellowship. It's a fellowship where you sort of get to take the next step of development as a researcher. I think it's often the case with PhDs that you get so focused in one particular area, one particular research methodology, one particular sort of field of research that it's kind of hard. It kind of almost defines you as a researcher. And I think while postdocs are common, I think this type of research fellowship is maybe a little less common, but it's really important in sort of opening up your horizon and expanding your horizon to all different areas of research and different ways of doing research. So I do consider myself very, very lucky in that sense to have had this opportunity. And I think also coming into this fellowship as a political scientist meant that I also had to learn new research methodologies, and I had to reconcile the way that I see research with the way that medicine does research. And also, I think part of the challenge was seeing that I can really make a contribution to medicine, and that I can maybe expand the sort of like medical approach to research, be it in relation to primary care, be it in relation to other areas of medicine. And so yeah, but with this expansion of my sort of like research horizon also came this sort of like an expansion of the types of things that I can do post fellowship. So when you do a PhD, it's this sort of like real cookie cutter kind of path. You do your PhD, you become an assistant professor, and then you get tenure, and then you move on into you live happily ever after as a faculty. And but this fellowship has expanded also my idea of what is possible as a next step. And I am, again, very appreciative of that. I would love still to have a faculty position, but I think to Hunter's point, it's difficult to have a faculty position, whether you have an MD or whether you have a PhD, and finding, these positions don't open very often. And I think especially as a person with a PhD who can't practice medicine, who's not a clinician, I don't have that leverage. And so what I have done, again, to Hunter's point, I have made contact with so many different people. NCEPCR has been instrumental for that. I sort of like really, for the lack of a better sort of term, I put myself out there, and I networked so much with people in AHRQ, not only to, sort of like talk about my own skills, but to hear from people where they thought the needs were, and to see how I could possibly fill up those needs with the types of skills and the training that I have. And I am also very lucky to have wonderful mentors, including David, who have put me in touch with various people, and who have also sort of guided me as to where to look. And I also think I have three very different, sort of like, for my core mentorship team, I have three very different mentors. I have one who's an ethicist pediatrician. I have a humanities scholar with a PhD, and I have a clinician only. And so all of them made it through different paths. And so also being exposed to that and seeing different ways of moving forward has been really helpful. So to answer your question, I don't know exactly where I'm going. I know what I want to do. I would still like to have a faculty position, and I have been talking to different people and hoping to stay at Penn State. But I do think that part of it is being open to different options.
Terrific. Well, I think this has been a great opportunity, Ro, for everybody in the audience to know what an outstanding primary care researcher we clearly have who's interested in next steps. So terrific. Hey, Josh, just anything you'd want to add to this conversation about how to think about next steps from where you sit? And particularly, it's pretty quick. You do your fellowship, you're already thinking about 6 months into it, what comes next.
Yeah, I think, having the mentorship and the fellowship granting access to mentors and to people who are doing the work in the field is invaluable. I also think it's, the funding is very, very difficult. I just want to make sure that we highlight more than half of all medical visits in the United States are to primary care, but less than 5% of all healthcare dollars go to primary care, and less than 0.5% of all NIH research dollars go to primary care.
Yeah, and who did that research, Josh?
I think that came out of the Graham Center.
Maybe so, yeah.
So I'm calling out stats of my mentors, which just shows how influential they are on me and how much I am in the right place. Yeah. But the funding is difficult, and finding somebody to take a chance on you is huge. And so the fellowships, and I agree with Ro that NCEPCR is such an incredible community, but finding the opportunities to make those connections and figure out where people's priorities are, because the nice thing about primary care researchers, just like primary care clinicians, is you can drop us into most any situation and we can be supportive. So if the academic institution wants to prioritize cancer research, well, primary care oncology is a growing field because more and more people are surviving cancer. If they want to focus on neurodegenerative diseases, well, they still get diabetes and heart failure and need a good primary care clinician. And so we as primary care researchers, and especially clinician researchers, need to be flexible and need to know where those priorities are, because primary care, I hate to sound like a broken record, needs to be the foundation of our healthcare system. There's no other way for us to reverse course.
Here.
Right.
Dave and y'all, as directors of programs, with your roles in helping people get to the next step, Dave, how do you handle this?
How to get to the next step? Well, we've heard a number of strategies. For clinicians, there's a clear advantage if you desire a role in a clinical department, and the quote unquote "one can always see more patients" rule applies. The goal in our fellowship for clinicians is to for not only clinicians, but it's especially attractive, is to have a K grant kind of ready to go. In fact, to have grants, regardless of acronym, kind of ready to go. A big chunk of the time spent is doing research and learning how to package research. And so the requisite elements of grantsmanship, for example, is something that we spend a lot of time with. And it makes an applicant much more attractive to a potential chair. It is risky, to say, from the chair's perspective, to allocate percent time that for sure won't be generating revenue for some time. And things are getting tougher and so forth. It still is the model, and and the necessity. And there are chairs who want to grow the research footprint of their department. I think that, one of the messages that has become stronger as I've moved through this career path myself is that from the perspective of a really junior person, I didn't see who's back there behind the curtain, and the fact that my boss had a boss who had a boss was totally it's totally opaque to me, right? But I learned that a conversation with the chair is something that the most junior person in the department can have. And as a person who is doing research, I could have a conversation with the research dean about my portfolio. The direct answer to the question, I suppose, is we've heard a lot about networking. We've heard a lot about packaging grants that can be implemented quickly upon hire. Talking to people as early and as often about potential opportunities is really important. If one is not a clinician, is there coursework in your academic center or academic medical center that need teaching or that can be developed? After it's all said and done, I think the mission orientation toward primary care research has been the key for us. Luckily, the chair that hired me has retired from that position. He was replaced with a chair who also, quote unquote, gets it regarding research, for which we're really, really grateful in our department. And on top of that, he's an operations guru across both the academic and the clinical parts of our institution, which structurally are separate, which they are in many institutions, but he manages to bridge them because he's lived and worked and been in leadership positions across both sides. And so, like, working with the people who can make those who can make those decisions happen, who can be deciders, and making oneself as attractive as possible to people who can decide, I think, is the strategy. We're working with that now. A few months prior to the end of our fellowship year, we're working that angle quite a bit with all 5 fellows in our class. What's next? We are not what's the career center part of our fellowship? We've got one.
The career counseling department, don't you have?
The career counseling department. We don't have a shingle to hang out, but for sure we spend real time on it. Yeah. And we have to. We want our fellows to be successful. The more successful our fellows are, the more likely we'll be funded again. It's ironic that the better I do in this job, the better it is for Wisconsin's reapplication process, right? It's a brutal calculus, but it's also good. It's also better for us. I mean, of course, better is better. All the boats float higher.
Yeah. No, well, and you're clearly your passion for mentoring is coming across, Dave, and what you invest in
you.
that. Yalda, anything? Yeah, any other thing you'd want to add about that sort of next transition?
I mean, I think a couple things. One, our fellowship is only a year. So you're right, Kevin, in that, I think the moment the fellows come into the Graham Center Fellowship, they have to be looking for their next job. I think advice to potential fellows out there is look at where the alumni of your fellowship, what are they doing? I mean, the Graham Center has a very specific, broad but specific path of what the fellows end up doing. We do health services research, but very policy oriented. And, the fellows generally end up working in institutions that are also very health services policy oriented areas. So that's one thing, choose the fellowship correctly. And then I always tell our fellows that your first job is not your final job. So that's why networking is so important. The first job you land in after the Graham Center Fellowship might not be your ideal dream job. You might not have, the ideal cut of clinical time versus research time versus, policy or federal agency time if that's what you want. But you have this background, you have made good connections with people in DC through your networking. Keep those connections going, and eventually you will land in the right spot at the right time. So, get a job and then go from there. A lot of times is the advice that we give.
Excellent. Couple thoughts. One, the other thing I think for me that was very important is not to feel like that first step out of fellowship, it means, oh, you have to be PI on all your funding grants. I had incredible mentors and great collaboration. So I was a co-investigator on several projects. So that was the other part that made the transition. I stayed at UCSF where I did my fellowship, but I think that's the other thing to really think about team science, your role as a collaborator, not feeling this is all just your individual, grant generating activities for your next steps, but how you can be funded in collaboration for grants that other people are on. I think a couple of questions are coming in. The ROI is really hard. I think the Dean Talmadge King at UCSF is always fond of saying, let's be honest, this is like chairs meetings, he would say, federally funded research never breaks even for departments and medical schools. You could be, including the, lab-based sciences and things like that, people with tons of federal grants, just because it is even with high indirect costs, because again, a lot of that gets siphoned off for parts unknown to your actual lab or your clinical research or the department. So I think for departments, for other entities that are committed to the importance of primary care research, it's going to have to take some internal research resources. And I don't think you can have the negotiations that there's a dollar for dollar return. And boy, you put money into these early career investigators, they will then generate enough future grants that will pay you back as a department. I mean, it is an investment. It is not, I think it's very hard personally to see it as one where you're going to respect a dollar return on investment. I think it is the broader question of, are we committed to advancing scholarship and translating the findings of that scholarship into ways to make primary care work better, to make our families and communities that we care for healthy, and a health system that is one that is much more health producing rather than personally wealth producing, which seems to be the main goal right now of so much of US healthcare. But so that's the endeavor we're on, but it takes a commitment. And I think this is where it's a story. There's, certain institutions that are traditionally very research oriented, like UCSF, other places where I think it's more of an expectation that departments will be doing this. But I think this is a challenge for many departments and for folks who've been putting comments in chat. There's such a spectrum, at least in family medicine, with some departments with very little research of this nature, as other that are in more research intensive universities that are much more well established. Like Penn State is really is an example of one that really made a transition and grew over time, with Mac Ruffin coming as chair and folks like Dave there. So I think we have to think of this broader, I think, as people committed to primary care research, how we collectively find the wherewithal and the will to do this. And that we then also feel accountable for making sure our scholarship is seen as valuable by our broader community. So I think this is where we work very hard at UCSF to say, how do we connect our research to the practicing clinicians, to the educators? I know some other departments have done this. Rutgers has done a great job. I think many departments have done this where there's, it really both is important to have the application and relevance of what you're doing, and again, to stimulate interdisciplinary collaboration, but I think it also creates more of a sense of shared mission for the research part of the mission, when clinicians, educators, others in departments can see why this is important and has meaning to the work they do. So I think that's on us to continue to make sure we're keeping those bridges fortified between the different sectors and our departments and our specialties and our fields. Okay, that was my chance as moderator to just do my editorializing. Let's, we're people have hung in there. I see the participants are winning away. Let's close. Let's look to the future. Maybe we talk a lot about the pragmatics, how you make research work, how you do the fellowships, how you find your way as a person developing one's research career. Let's start with maybe our fellows. From where you are in your stage of career, what do you think of the most, what's one or two of the most compelling questions front of mind to you? And where do you think we need to push ourselves to do better primary care research, to really embrace more transdisciplinary mixed method science? So maybe Josh, I'll go back and start in the order we began. I mean, I know you're very policy oriented. We're thinking, well, what's most front of mind to you, and what do you think are the key compelling question that you really think we need to tackle, and then how do we really push ourselves to do this better?
So we're ending with a small question. I think the question of how do we pay for what we want is the thing that keeps driving me, with the acknowledgement that much of positive healthcare, as opposed to treating disease, is going to happen outside of the clinic walls. And so how do we as primary care researchers and primary care clinicians escape this one-to-one view of physician or clinician and patient interaction? And how do we put that into language that our policymakers and our cross-disciplinary researchers can understand? And unfortunately, typically that is ROI, and that obviously introduces complications when it comes to primary care research. But how do we frame our research as benefiting the communities, while also acknowledging that if we do better primary care, that is going to lead to missed revenue for other parts of the healthcare system? Kevin, I know that we've had conversations about this, about being cautious about saying that paying for more primary care will save money. But the research shows that if we're better at primary care, our system becomes more efficient and our funding streams go elsewhere. And so how do we support that and help everybody understand that's actually a good thing?
Wonderful. Ro.
Thanks, Kevin. So, I mean, I have way too many questions in my mind, and I think that's part of the issue with sort of being someone trained in politics and international relations. My brain functions, as sort of like always at the big picture level with all sorts of different questions. But one thing that I am, as a political scientist who researches primary care and, more specifically sort of like child wellness, I am interested in asking, how did we get here? And how do we create how do we better sort of like equip our clinicians, but also primary care researchers, to also see the historical origins of the current primary care system that we have, and how can we make it better for all Americans? How can we improve it? And I suppose, I am really, I sort of like my approach to research is sort of like historical, political scientist approach. And I think that it's important sometimes to look in the past to see how we can move forward. And one thing that I have found at least in my sort of like experience at the College of Medicine, is that often for at least the students that are coming in, they don't really have a big focus on medical history, even primary care history. How is it that we maybe went from a sort of like comprehensive model of primary care to a very, more sort of like limited model of primary care, where we're primarily just treating disease rather than actually treating health and well-being, health as broader than that, right? As not just the absence of disease, but as a sort of positive thing. And I see that there is a huge lack of that. And I also, from some of the physicians that I speak with, I think there is also a bit of a lack of, how do we get here and what can I do to change it, to make it better? And I think that this, obviously this group is well beyond that, and everyone's already thinking in terms of policymaking, in terms of improving the system. But that is something that that I'm really interested in, and that I ask, how can we also not only make it better, but put in place a framework to help clinicians and help primary care researchers to regain their agency to make this a better system.
Love that from Josh's sort of the policy and the compelling questions of the day. And I love Ro talking about partly you have to know how we got here to figure out what are the lessons to then being able to solve these problems. Hunter, last word from you on where are we?
Well, I just want to say, we had like almost an hour and a half. We haven't really mentioned the mentorship aspect, which I think is probably one of the most important aspects of these fellowships. So just throwing it out there, much like you're one of my mentors, Kevin. But in terms of healthcare, there's this crazy statistic that people are on their insurance for an average of 5 years, and then they're going to go switch to be unenrolled or be on Medicaid, or if you happen to live in a Medicaid expansion state, and then you're on another private insurance, and that might mean you have to totally switch your healthcare from health system A to health system B, even though you've been at the same health system. I literally have a 70-year-old person that they just got onto Medicare, and or 65, and they've been with the same doctor for their whole life, and now they have to see me, and they're not happy to see me, even though, but I'm going to do my best. But that fragmentation of care, and I think as healthcare gets more and more expensive, people are going to be turning to these federally qualified health centers to really provide that care, and that's often manned or by family medicine physicians and primary care physicians. And we try to do it all, but there's going to be times where they need to go to their specialists. There's going to be times when they need to get a biopsy for the mammogram findings, or the PSA is going to be high and they're going to have to go see the urologist. And that disconnect, I mean, I'm sure everyone has tried to request medical records, but it's so difficult. And the success rate, I think, is so hard. And when people switch health systems over and over and over again, maybe even 5 times in their life, how are you expected to get medical records from 25 years ago, which might be relevant? I'm specifically thinking about vaccine history and things of that nature. And so that's where a lot of my research is right now, is trying to, how do we navigate that fragmentation of care, especially in terms of cervical cancer screening or cancer screening in general, especially from these federally qualified health systems. And so not as policy or history oriented, but I think a real reality of our health system. Thank you so much, everyone, for your time.
Terrific. Yael and Dave, is there any, in 30 seconds, any parting comments you want to make before we wrap up?
In my am I on yet? In my perfect department, the word silo has a kind of a historical context, like it is a thing in history, like we have done away with it, and that the clinical enterprise knows something about the educational enterprise, knows something about the research enterprise, and that there's a fluidity between the three, and a respect across the three, and not everybody does all of those things, but everyone understands that they're integral to an academic family medical department, and academic medical center, and so it'll be obvious that some of the bits are really revenue generating in the model that we have constructed, and that there's a pride in supporting the other two missions, which are less revenue generating. And we're not there in our department for sure, but we're not not there. There's not an antipathy to those things. It's just more of an absence, right? And it is incumbent on educators and researchers to make it clear, to make the value of those enterprises clear for the whole departments. We know that the better the research division does, the higher is the caliber of our applicants for med school, for residency, and for faculty. We know that 100%. And so that it's just one example of the non-monetary but totally important wins associated with research. I think that again, it's on us to communicate some of these things to open-minded, open-hearted, willing listeners. We're fortunate to have some of those at Penn State. Again, it's a moment, and we're trying to seize it. But that's my dream. I wake up every morning with it, and some days I feel like I've walked a step in that direction. Other days it's like, dang, that was a step back. But most days I think we're moving the needle forward.
Well said. Yalda, send us off.
No, David said it well. I'll just add that, thanks to the attendees who tuned in and stuck with us. We want primary care research to grow. So, if there were questions out there that we didn't answer, I'm sure that Kevin and David would agree with me that if you're a learner, future researcher looking to go into primary care research, please reach out to us. We can help answer more questions for you. We need more of you in the field. So please don't be discouraged by the current environment. We really need you to go into it.
Time, it's a big one. To that point, time does not seem like it's on your side as an early career person. It totally is on your side.
Yeah. All right. The life course perspective. Look, hey, thank you all. Yeah, thank you for our attendees for hanging in there. Those who are still with us. Amy Eden and her team at AHRQ, waving the banner still for primary care research and keeping the National Center for Excellence in Primary Care Research still visible and active and supporting in whatever way they can the research and scholarly endeavors in the field. Thanks to Diane Fraser and Claire and other folks at APT for producing the webinar and getting it all organized. And again, colleagues on the panel, thank you all for your incredible insights and collaborative approach to this webinar. So with that, I think we will close. For folks on the panel, maybe just stay on so we can just touch base for a bit afterwards, but we will send everybody else on their way. Thank you all.
Thanks, everybody.